All right, we're going to talk about distal ulnar fractures and if we actually should ever fix them. So hopefully by the end of this talk, you may think twice about ever having to fix them, which is good news for anyone who's tried to fix one in the operating room. First, I want to talk about anatomy, but we can actually skip a lot of it because Dr. Rosenwasser addressed the ulnar side of the wrist, particularly from the radial side. We'll talk about distal ulnar fractures, treatment options, and then a little bit about surgical approaches. I think we all know when looking at the anatomy, there's a lot of anatomy that you don't see on an x-ray that helps to stabilize a distal radial ulnar joint, whether it's part of the interosseous membrane, which is that dorsal oblique bundle that you see on the distal aspect, the TFCC, and then certainly the ulnar head, which is primarily the styloid and the dome. When you look at the cross-sectional anatomy of a distal radius and ulna, you can see that there's a different radius of curvature of the radius, which is larger than the curvature of the ulna. And certainly that is affected with pronation supination. It's kind of a sloppy joint there. You can see it in pronation and supination. It actually slides back and forth. And when you're looking at the soft tissue anatomy, the TFCC, which is what helps with the stability in addition to the bony anatomy, you have the insertion into the radial, or into the ulnar styloid at the tip as well as at the base. And again, what you can see here in this nice anatomic specimen here, you see the TFCC, the dorsal and volar radial ulnar ligaments, and then the importance of the sigmoid notch as it pertains to the DRUJ. So why is the ulnar side of the radius so key? Well, we know that there's a short radial ulnar ligament. We talked about the lunate facet and how critical that is for fixing in a distal radius fracture. The volar lunate facet is more convex and it extends more distally, which is why we talk about getting that plate as distal as you can. It bears more load than the scaphoid fossa and obviously the sigmoid notch. And so when we talk about ulnar-sided injuries, it's always critical to talk about those ulnar-sided injuries of the distal radius, but that's not what we're talking about today. We're primarily talking about ulnar head and neck fractures. We talked about the intermediate column being the foundation of the DRUJ and how extra-articular fractures can involve that sigmoid notch rather than the really being intra-articular in the distal radius. It's intra-articular in the sigmoid notch. When we think about ulnar styloids, there's several ways to classify it. There's the original AO classification, which incorporated TFCC, distal ulna being the small fragment, the larger fragments, the heads, the neck-type fractures, and then the comminuted shaft fractures. And then there's really kind of main types when you think about the type 2 fractures, and the ones that really care about are those base fractures, and then the almost like subchondral or subcapital fractures that you may see. Isolated ulnar styloid fractures, you really don't see in isolation. Most of the time they're associated with distal radius fractures. Good news is you see it about over half the time in distal radius fractures, but it doesn't really matter. Most of the studies show that there's no difference, that about 60% of distal radius fractures have ulnar styloid, but it really doesn't affect function in terms of most of them go on to non-union, but they do find in terms of functional pain scores in both when you look at union and non-union. Now, I have a little bit of caveat here in that there was just an article published this month in Injury which shows that non-unions have a little bit more pain. So it does certainly affect which article you read right before you give a talk, but most of the historical data is that it doesn't matter. So the way that I think about ulnar styloid fractures is you always want to fix a distal radius, and then you want to look at the stability of the DRUJ that we saw with that Shuck test. And if it's unstable, then you have to consider fixing it, but really what you need to do is address the distal radius and say, did I get anatomic fixation? And if you didn't, maybe look at that, get your length back to incorporate the dorsal ulnar bundle and the tension that helps to recreate stability of the joint. So most DRUJ are stable after you fix a distal radius. So if they aren't, like I mentioned, check that reduction and then fix the styloid like we saw with the use of either, you can use a K-wire tension band as you see in this x-ray here. You can fix it with multiple K-wires alone without any tension banding. You can use it with a suture anchor. There's many ways to fix it. And then often the question we get is, do you just pin the DRUJ? Certainly you can do that, and that's a reasonable option, or you can go ahead and fix it. So when we think about truly distal ulna fractures, there is a classification which is given a Q modification through the AO, which talks about them in relation to distal radius fractures. And then there are isolated distal ulna fractures, and you can see that with the new modification, you can see there's many classifications that you can give it. Really, why are they so difficult? And when you think about distal ulna, and everyone's probably struggled through one of these cases, whether it's with me or my colleagues or in the middle of the night, they're really difficult because they're often very comminuted. It's often in very, very osteoporotic or comminuted bone. Oftentimes you're struggling where to put the plate. Sometimes there's so much rotation in the distal ulna that it's actually hard to figure out where is volar and where is dorsal when you're looking at these very mobile pieces. And then it's really thin skin, so wherever you put the plate, you have to think about, is this gonna really bother the patient? So historical data, when you look back at these studies and you say, you know, in the 90s, when you read these articles, and these are the classic articles out there, everything was fixed, right? So you would fix the distal radius, you would fix the distal ulna, at least with K-wires or something. And then in the 2000s, it ended up being kind of dealer's choice. You can find a paper that says fix them, find a paper that says doesn't fix them. And what kind of is a difference was actually the innovation of the volar locking plate, which changed a lot. And that goes to underscore the need to get a adequate reduction of your distal radius before you even address the distal ulna. And so where are we today? Well, if you look at this study by Namba that was in 2019, most distal ulna fractures are in elderly population. And again, most of them are associated with distal ulna fracture or distal radius fractures. And what they showed is that you can actually, all these fractures went on to union. And they actually had no DRUJ instability, and clinically they were doing well. There's only one case of DRUJ widening. And then, so this basically says we don't need to fix these. Here are two examples from one of my partners who treated these non-operatively. Again, it kind of underscores the importance of fixing the distal radius, assessing the distal ulna, see if there's actually any motion when you're looking at this. So this, taking it through a range of motion, looking at under fluoro, see if there's any fracture mobility, and then deciding whether you need to fix it or not. So here's one fracture that you may have looked at initially and said, oh, we need to fix them both, but then it goes on to heal because she got an anatomic reduction of the distal radius. This is even in a younger patient, a 57-year-old, and you can see here that it's actually quite displaced, but after getting reduction of the distal radius, the ulna was stable and went on to heal. Now, I will tell you there are instances when you do fix it, and then these are usually in the middle of the night when the bone is sticking out of the skin. This is a 73-year-old that we just did recently. You can see how displaced that distal ulna was, and if you look up closer, we do have a CT scan that shows you how comminuted it was. This is an open fracture. And after we fix the distal radius, you can see how displaced that distal ulna. And that's a near anatomic reduction except for that comminution that you see on the ulnar side. And we went ahead and plated the distal radius, which was a real struggle. The resident is here with me, so he can attest to that. But you know, it's very difficult to figure out position when you're working on this, and there's so much comminution to align it. So I think that, you know, raises the question, do you actually even need to fix it? Moving on quickly to distal ulnar shaft fractures. You know, the studies are if it's less than 50% displacement or less than 10 degrees of angulation, you can cast these. Most of these do go on to heal. If it's greater than 50% displacement or 10 degrees of angulation, then you want to fix it. Things to think about in a surgical approach. So you really can approach the distal ulna kind of any way you want. It's a dealer's choice. You can get there volarly, laterally, or dorsally. Most of the time you're doing these through a straight lateral incision. The complications, you know, as we talked about earlier, it's really important to know where that sensory nerve is. So that dorsal ulnar branch of the ulnar nerve comes off about 5 centimeters proximally, and it's important to look and trace out those branches if you're going to put a volar plate or a dorsal plate or a straight lateral plate. And do know that most of the time when you put in distal ulnar hardware, you're going to end up taking it out. So you can also go through a dorsal approach. This was Garcia Elias published this in 2003. You can make a kind of curvilinear incision, or you can go through this kind of dorsal zigzag incision. You're elevating right through the dorsal capsule to get access to the TFCC for repair if you need to, as well as to access that distal ulna. So methods of fixation, as I discussed earlier, you can do it with a cannulated screw. You can use those 2 K-wires. If you're going to do a tension band construct, you're drilling a volar, either an A to P using a small drill like a 2.0 and then using a tension band construct around K-wires. And then there's always options to use wiring or certainly plate fixation. There's plenty of plates that are constructed for the distal ulna. There's also plenty of plates that can be bent. There's my recommendation, if you're fixing one of these distal ulna and you don't have ulnar specific plates, make sure you ask for a locking set because you're gonna need it, because most of the time you're really only able to get 2 screws, maybe 3 screws into that distal fragment. You wanna have the option to use locking for the amount of combination that you'll see. So what about that really, really combinated fracture like the one that I struggled to fix? Well, you can leave it. So a lot of the data out there says that you can just leave it alone, see if it heals okay. Certainly you can come back later and do a DARA or a distal ulna resection. You can try and fix it, and you can use a lot of cuss words when you try and fix it. Or you can do something later and do an arthroplasty. So you can see here's a distal ulna replacement. So there was a poster presented in the Hand Society a while ago talking about ulna fractures, and these were showing treated with DARA, the ones that had an ORIF, and the only difference in long-term outcome in terms of range of motion and pain scores were equivalent, but there was a much higher complication rate, as you can see in the bottom, with the operative fixation versus the DARA, which is the distal ulnar resection. So there's a long list of salvage operations that we don't need to go into today, but here they are. You can do a DARA, you can do a Sove-Kapanji, you can replace it, you can replace part of it, or you can use this Schecker prosthesis here, which is very futzy. And so hopefully you never have to go on to do one of these. But the majority of time, ulnar fractures don't need to be fixed. What I recommend is, since most of the time these are associated with radius fractures, really, really focus your time on making sure that the distal radius is well reduced. Try and get that anatomic, check your DRUJ. Make sure you always check your DRUJ when you're walking out of the OR. And then think twice about those basilar or oblique ulnar styloid fractures. So the bigger the ulnar styloid fracture, the more displaced it is, the more you should think about maybe needing to fix it. And then in the comminuted elderly patient that has that distal ulna fracture, thinking about just leaving it alone. So thank you very much.